Hey, good evening, everyone. Trying to, uh, Dr. Jovanovic and I have been trying to connect for the last 20 minutes, but the technology seems to be, I think there may be issues with Instagram right now. So we're trying one more thing and hopefully this will work. Okay, Dr. Jovanovic, I just accepted the request to join. Hopefully that works. Hey, there it is. Hey.
You got
I feel like Instagram stacked the odds against us, but here we are. We overcame.
uh,
How are you doing this evening?
good, good, good. Good to see you, Shane. Like I know you had some troubles there, but we're here, and I see that some doctors are joining us.
Yeah, I see people are flowing in. We're already at 30 people, like 1 minute in. So appreciate you taking some time to join us, and appreciate everyone else joining us this evening. Sorry a little bit later than advertised, but we had some technology issues which we seem to have solved. So let's jump in a little bit. So I think one of the most interesting things maybe to discuss it with you is education, because so much of your career has been focused on education. So you were one of the pioneers of guided bone regeneration in the Gore-Tex days, and so I'm sure you have some cool stories to tell from those days, and kind of coming up with what is still the modern day gold standard for vertical ridge augmentation, and also works really well for horizontal. But for education, you have the Guide Institute, you have the Global Institute for Dental Education. I would imagine that you're one of the two or three, like in terms of doctors who have educated people. Like you've got to be right up there with educating, one of the most. So maybe you just talk a little bit about what made you so interested in education, and why what led you to start Guide?
Okay, okay, that's a good one, Shane. Thank you. The fun part is for me always when when I walk around with my kids around the world, and that could be like in Europe or in Asia, and I get approached by somebody on the middle of the street. And then my kids all think like, oh my God, who my dad is so famous. I said, no, dude, that's not famous. Just like another dentist that I came across in a conference somewhere. And so I'm just joking around. But like, obviously, it's been a really, really good life. And I really appreciate and I'm very grateful to all the fantastic, doctors that I met all over the world and that, wanted to be trained by me and obviously by myself and my colleagues. But the journey really, I think, was started really early because, when I started to learn about implant dentistry, it literally there was nobody else doing it, and I was probably like at that time like one of the young guns because I was like I would say like 22 or 23 when I saw the first Brandemark implant at the university where I was graduating, Amsterdam. And then I somehow had the foresight, probably my dad helped me a little bit. He was a cardiologist.
Okay.
I said, Dad, like, you know what? I really need to learn more about this because like dentistry is maybe not really for me, at least the dentistry that we had in the 80s. But this implant stuff is really, really, really cool. And then um, I went to the US to Loma Linda University. When I came back from that graduate program, which was the first implant program, I went back to Europe, and then literally all my buddies, they just wanted to learn about it. And then I fell into it but just kind of, yeah, my buddies who I usually would hang out with, teaching them how to, place implants, explaining them the biology, explaining them the biomaterials. And then at the same time, of course, like I was fortunate enough, again, I fell into implants, but then I fell straight into regeneration because at that time, periodontal tissue regeneration with the Gore-Tex membranes was alive. And then we learned very quickly that, actually bone regeneration was much more successful than periodontal regeneration. And then I got some cool young other guys, maybe a little bit older than I was. Daniel Boozer, you know, from ITI and from Straumann, who started to work. We started to work with each other. We started to compete with each other, and then Massimo Simeon came on the, you know, on the scene, and then we started to like be friends and compete with each other. You know, who can do a better surgery and who can teach it better. And so it was kind of just like a genuine getting into it. So, and then I realized really quickly that you know what, I can probably place implants for some patients, but you know, I got only 2 hands and 1 body. I can probably place a lot more good implants if I share my experience and my knowledge and have fun doing it. So I learned very quickly it's better to teach other people how to fish than feeding them fish into, you know. So that's how I started.
Awesome. So in the early days, you mentioned Dr. Buser, Massimo Simeon. Like, I guess like some of the first publications were in the early '90s, right? And I know that you were the primary or co-author on several of those, and also some of those patients that you treated in those, like you still follow up. Like I think it maybe 5 years ago, but you were talking about you had like I don't know, it's something like 25 or 30-year follow up with a patient with implants placed into regenerated bone. Is that right? Like what's like maybe the question is like how far of follow up do you have since you have some of the longest time with these procedures?
Yeah. So you know what? It's really incredible because I was about a month ago in Italy for a conference with Simeon and with Boozer, and so the 3 of us, like, you know, are kind of the 3 musketeers, and then we were sharing some cases of ours, and it's incredible that like some of these patients now are going definitely into 25 plus years. And you know, they're still like super stable, and of course we've had our fair share of complications because, you know, you can't like develop a technique without running into failures and into complications. But those cases that did well are now really definitely into 25 years. I just saw my mother, who's kind of a really interesting story because I treated her in like 88 89 with implants, and she got like simultaneous GBR with the Gore-Tex membrane.
Okay.
And then she got like even one of the first alumina implant bridges. This was before zirconia. And that was just like the time between Europe and the US. And then, so basically that was in 1990. So she's now 33 years into follow-up, and thank God she's still alive as my mom. But also, like, you know, she still has that alumina bridge on 2 implants which were regenerated with a simultaneous membrane technique. So that's, I mean, it impresses me when I see those cases.
Is it the same implants that you placed 33 years ago?
Yes, the same implants. Yeah.
Wow, that's impressive.
Yeah. Yes, the same implants. You know, they were the original machine turned Brandemark implant with an external hex.
Yeah.
And yeah, like all those cases, but basically all the cases that we have now, the 25 to 30 years, let's say Simeon and myself, there was, you know, basically 100% was a machine turned external hex Brandemark implants. And of course, Boozer, his are all like more tissue level, Straumann implants placed in a staged approach.
Yeah. So shifting gears just a little bit. So we started off talking about education, and by the way, for the audience, if you guys have questions, you're welcome to drop them in the chat, or there's a question button that you can check here. But one of the questions about getting into implant dentistry, which I think is one of the questions that I'd want to ask tonight. So, like, as someone's getting into this and they're starting to do GBR, and I think there's a skill level, right? There's like you kind of have to build these skills as you go. And I feel like, in my opinion, and I'd love to hear your opinion on this, but vertical, ridge augmentation is sort of like the most difficult. It's sort of like excluding, there's some difficult soft tissue procedures too, but from a bone standpoint, it's kind of the hardest to grow. And so where do you start? And then what does the progression look like, and how does education fit into that?
Right. Well, I think like, you, the good thing is like, it's a procedure which obviously demands a lot of attention to excellence.
Yeah.
So you cannot do this procedure. It's a specialized procedure. So you as a dentist really, or as a clinician, whatever it is, like a specialist or like a general practitioner, you need to make the switch in your head to say that every single step that you're going to be doing is going to have to be attention to detail. So there's basically no shortcuts.
Yeah.
And then of course, like you have to make a decision also that to exclude a lot of patients, because as this is a specialized technique that needs really a certain amount of clinical skill, you also need to accept that like this is not for every patient, because you cannot do let's say a transplant procedure and then send that patient out to go run, or like send the patient out to go eat whatever they want or start smoking. So this kind of is a very similar procedure. The patients have to be selected. So basically, I use sometimes the word in my training programs. When I accept a patient for challenging guided bone regeneration procedures, they need to earn it. And if I feel that they will earn it, I'm happy to do it for them. So that's one. And then thirdly, I think also like it's really important, and I'm happy to do this Instagram live with you guys from Osteogenics, is really to understand which products do I need to use, which biomaterials do I need to use, so you don't make a mistake. Because the protocol is after 30 years now, we're lucky that we have published it, we have refined it, we're training a lot of people around the world how to do it. But you got to stick to the protocol. Yeah. Because if you change the membrane, if you change the autogenous towards 100% biomaterial, if you use like poor sutures technique or poor suture materials, all that will affect the results. So it's really like of course I would say it's not such a hard technique to do if you do everything right.
I think those are so the 3 points that I'm hearing is one is I mean, patient selection is probably like the most important one. The second one is the details matter a lot, and I think that's something that we've seen. Sometimes people take a course like like you guys offer, and then they want to kind of blend that with the way they also like to do things, and then sometimes that doesn't work. It's because I know there's a lot of research. There've been a lot of things tried and a lot of things didn't work to sort of get to this. Among I guess those who do the most teaching and have the most success, there's like some general, probably almost like agreement in terms of what to do and what not to do. And then I think education's a big part of that too. For me, well, I want to ask you this question first. What do you think is the number one when people start doing ridge augmentation, and they have failures? Like, what's the number one cause of it?
Well, number one cause, well, a complication after ridge augmentation using a membrane technique is probably the number one complication that people will see is, of course, the membrane exposure or the incision opening. Now, what causes that? I would say the number one reason is not knowing correctly how to release the flap. Yeah. But then at the same time, we got to start that, that we cannot point the finger towards just like, hey, the clinician doesn't know how to release the flap, because it often starts already with the soft tissue condition that the clinician is faced with when they start the procedure. Yeah. And then how is the flap elevated, right? Is it like a really clean, full thickness flap elevation with a nice remote vertical incision that really opens up the site really well? So yeah, it's kind of, I feel like, sometimes basically like I would put it more under the overall umbrella of soft tissue management, which basically prepare the soft tissue first, then make the right incision, make the right full thickness flap remote, and then once you get there and you do everything, then comes the release. And then, of course, comes the last thing, which is the last piece of the puzzle to close it, is really your suturing technique and the suture material that you use. And of course, you guys, I'm so kind of excited and happy that you guys have such a good suture line, and that you put like, a good emphasis on that with the cytoplast, PTFE, and then also the addition of your Resorba line, which is a great line. So I use both of those, so I'm very happy with that.
Yeah, I mean, the flap soft tissue management, flap release, I think those are the two things that we often see are the most common. There's other things you have to get right, but I think that's the most common because, I mean, the release, it takes a lot, right? Like you're growing bone vertically and you need this double layer closure. So the amount of additional tissue that you need is significant. And I think sometimes it can be a little bit underestimated early on in one's like learning curve to do these procedures. And you talk about the double layer closure. I think that's something that not everyone understands, and I think that's a really key point. Could you describe that a little bit and why it's important?
Yeah, of course. Like the predominant thing is just to already see is that when you're closing a flap, and you can imagine already when you're just trying to adapt the margins of the incision together, if you would just butt join them, obviously with using, for example, a single interrupted suture, you'd get like a butt joint, which is going to roll inwards, which means like the tissues will be like kind of rolling towards each other with epithelium facing each other, which then automatically will give you, especially if you have a non-vascularized surface underneath, like a membrane, and a problem with healing, so a secondary healing, which then, of course, like results into a membrane opening. So what we're trying to do with a double layer technique is basically doing the opposite. So you're trying really to try to figure out how can I get the flap margin, like, to go upwards. So if my fingers, the inside of my fingers would be like connective tissue, that you're coming up and that you get connective tissue against connective tissue in like maybe a distance of about 3, maybe even 4 millimeters. So like you got a lot more solid, healthy tissue, which is being promoted. And then of course you do need a suturing technique to hold those flap margins in this like everted coronal position. And that's of course like, our suture technique, which we train so many dentists in for so many years, the horizontal mattress technique. And then, of course, also you need a good suture material. So that's why we use exclusively for that eversion technique or the mattress technique or the double layer technique, we use a PTFE. And I usually use a Cytoplast 3.0, which sometimes is, like very, very easy to use. It's like, it's just like, it's a suture which kind of allows you to have some elasticity. I do a very careful closure of that too. So like, my first knot, which is usually on the buccal side of the flap, will be like a double knot forward. And then my second knot is like a reverse single. Then the third one is usually like, again, an, reverse or like the counterclock forward. And then my last one, I do 4 knots, which is again a double lock.
Okay.
So I'm very careful in suturing. And also like, if I'm not spot on with my first suture, or it could even be the last suture, I'm taking them out and I do it again.
Okay. How often does that happen?
It happens. It happened. Yeah. Like, I just recently did the live surgery. Like it was a big conference. It was like a 1,000, happy people watching. It was like some crazy vertical case in the anterior maxilla. And man, I was so unhappy with that suture. So I had to remove it. So they had to suffer through it that I just placed a mattress suture and then I had to remove it. I had to do it over again. But yeah, I needed to do it. So what can I do?
People love that though. I feel like, especially, with clinicians like you who have, are having a lot of success and a lot of experience with these things, it's like to see even a little bit of failure is somehow like rewarding for the audience. It's like, okay, yeah, this stuff is challenging even in the best hands.
Yeah, that's true. True, yeah.
So,
Yeah.
so the PTFE suture. So, why do you choose that for your crestal closure of the ridge augmentation procedures? Is it, you talked a little bit about its elasticity, but is it because it's soft? Is it because it's monofilament? Is it because it's maintains tensile strength? Like, what of the properties is most important for that application?
Well, I think it's like really like when we started using the PTFE was of course like very new to us, and it just came automatically because like the membranes at that time had a PTFE suture, so it was just like an automatic. But like, I mean, if you compare it to any other suture, it has everything that other sutures don't have. So like, it has tensile strength that you can tighten, let's say a second or third knot still and tighten it up. It's soft, so you can leave it long, hanging there, and patients will not be bothered with it. And it's biocompatible, so you can leave it in there for 2 weeks minimum. You can even leave it in for 3 weeks.
Yeah.
You can even, if you make a mistake and you cut the suture upon removal, and the suture disappears in the tissues, the chance of that getting like a suture abscess is like very, very low. I mean,
Okay.
I have so many cases over the years, over the 30 plus years, that I went back into uncovering later on, and then damn, I found like a little suture which just got trapped in there, but it's laying there. It's not
really?
like, it's not infected. It's just laying there, and then you just say, "Oops, who removed this suture?" And then they say, "You did, doc." I say, "Oops, okay," and then so that's good. And then yeah, I mean, all the ingredients. This is like an all-round, by far, the #1 suture for this kind of procedure.
Okay. And then the you mentioned the glycolon. When are you using that? Are you trying that for any crestal closure? Because I know we have customers that do that. It resorbs. I mean, it loses half of its tensile strength in I think 10 to 11 days. So, for crestal closure, it seems like maybe not ideal, but I know people are having like some people are swearing by it. Like, but for your practice, like, are you just using verticals or when do you use it?
Yeah, I would let's say those colleagues who are doing that, I'm happy that they're having, comfort zone with that. But I mean, if they would be like my students and they're learning from me, I would say, you know what? Yeah, you can do that, but like I wouldn't do it like on big cases.
Yeah.
I wouldn't do it over PTFE. I would maybe do it for collagen membranes, resorbable membranes,
Mhm.
natural collagen membranes, but I wouldn't do it over PTFE. It's just the risk is too high because as we know, when you're doing a PTFE horizontal and vertical ridge augmentation, unfortunately we have a couple of percent of complications.
Yeah, sure.
So we cannot be 100%. But whatever I can do to limit a risk factor, I will do. And for me to use a resorbable suture for to close everted a double layer technique, it's just not worth it.
Yeah.
And I got a great suture, so why not? So what do I do then? I use glycolon in pretty much all my soft tissue mucogingival work.
Yeah.
Pretty much 100%. I use it on vertical incisions. It's fine. And I use it for like any kind of palatal work. If I do like tuberosity work or soft tissue harvesting work. So I'm definitely a fan of glycolon. I think it's a fantastic monofilament resorbable suture, which is really stable. I mean, it stays actually around for like 2-3 weeks, easy. So yeah.
Okay.
And
No, soft tissue, vertical.
I want to add something to this here. This has nothing to do with biological or biocompatibility, but you know how many times patients, especially here in the US, they have such a busy life and they don't want to come back, or they're like hesitating to come back. I mean, there's one thing that I can control them with. If I put a suture in their mouth that's non-resorbable, they're coming back.
Okay. It's a good point.
So it's like they're coming back. So, and I want to see them, right? I just did like a very complicated, horizontal vertical ridge augmentation for them, which is very important for them. So I want to see them. So I'm placing a non-resorbable suture.
Yeah, that's interesting from patient management standpoint. I had that's something that makes a lot of sense. Um, Healing time. How long for? So we're just for the audience that has joined. For one thing, if you guys have any questions, we'd love to include your voice in this discussion. You can make it in the comments, which I'm kind of monitoring, and also there's a question icon that you can click, and we'll try to get your questions answered. Um, we probably have like 5 to 10 more minutes here with Dr. Jovanovic. But so on this ridge augmentation, how long are you waiting to go back in, presumably to place your implants from graft surgery to implant placement?
Um, I mean, we use like a standard biological healing time, which is usually like about, like I'd say 4.5 months for the smallest extraction sites. On average, I would say for anything which deals with like a critical size defect, which is basically external bone grafting, so lateral bone grafting on top of implants, it's 6 months. If it's simultaneous implant placement and lateral ridge augmentation, it's also 6 months. I think it's really important that like we allow the body to heal. Also, remember, like, for the longest time, we focused so much on bone to implant contact.
Yeah.
So osseointegration. And for decades, that was the biggest discussion we had in implant dentistry. Will that damn implant, integrate?
Yeah.
And now that, like, we're pretty comfortable with believing that, like, almost every implant in a healthy patient will integrate, now we're jumping the gun with guided bone regeneration or other types of grafting to put in implants quicker and load it earlier. So I think it's really important for those of us who are really taking regeneration serious, and I know you guys do at Osteogenics, is to go back to those years where we learned about osseointegration and bone to implant contact. Because, one thing is to regenerate tissue. So one thing is to, place a bone graft, to allow the blood, to basically stabilize their bone graft, then revascularize it, then of course start the mineralization process and everything. So that's one thing, and that usually takes about 4.5 months, and then depending on the defect, it can take longer. But imagine now, while this bone is being regenerated, and all this tissue is starting to develop itself and lay its cells and its mineralization on top of like some kind of scaffold. Now you place a titanium implant in there, either like, with an oxidized surface or like whatever surface it has, rough or, somewhat developed. Now you need to get bone to implant contact. So this fresh bone, you just told them, like, the fresh bone to start growing. And now you're telling that fresh bone, hey, by the way, yeah, that's good that you're growing, but can you grow towards that titanium implant there to the lateral? It takes a lot from the body. So I say let's respect that, and let's wait, really the proper amount of time, and you don't have to rush it. Patients can wait. It's a regeneration. Yeah. And so I'd say 6 months for, small to intermediate, 9+ months for large.
Okay. Got it. I had a question here, kind of going back to the suturing. We had a question from a doctor about the what knot do you do with the glycolon suture for to stabilize it and to keep it tied?
Oh, like just like a locking mechanism?
Yeah, just the knot security is the way I understood the question.
Okay, yeah. I mean, I'm not too fancy on this one. I just make like a double knot, going after securing it. And then I'll do like, a reverse single knot, and I'll do another single knot, and then I'll do a double knot. So I think the reason that I have had, like, I would say almost two main reasons that I believe that I've had no issues with sutures. Okay, I'll add one more, third one. One is like I use a good suture, and I think Osteogenics has great sutures. Number two is I take deep bites. I see in a lot of my training programs, I see so many colleagues, like, doing a nice suture, but they're just too close to the incision margin. So I take deep bites, which means like about 3 to 4 millimeters away from the incision margin. Okay. And, number three is like, I do 4 knots. That's like, it doesn't matter what I do, I make 4 knots, and it doesn't come loose.
The deep bites is interesting. I think that's an important detail that you mentioned there. So you're saying 3 to 4 millimeters is your definition of a deep bite. Is it for to not mess with circulation, or is it to not pull through, or what's the rationale for the deep bite?
Both. So like, not to pull through,
Okay.
and of course also for revascularization. And if you do a double layer technique, of course you need to go a little bit deeper, meaning 3 to 4 millimeters, so you can get that eversion, so the flap, can go up, and then you have that 3 to 4 millimeters of connective tissue or collagen opposing each other.
Got it. Yeah, I think when you talked about details earlier, I think these are the details sometimes that can be the difference between success and failure. And I think that's where leveraging your experience is very valuable. So, a couple more questions, and we're getting close to the end of the 30 minutes. I guess before we get in, I want to get into a little bit more of an educational discussion as the last one. But before that, like, what do you think is the future of bone grafting? I mean, is it growth factors? Is it like what do you think? 10 years from now, are we doing things differently? Because if we think about some of these things, there's like the PTFE membrane was it was early 90s, and it's still the gold standard. Some like 30 years later. And and there have been some modifications along the way, right? Some improvements. There've been some changes. But do you see a big shift? Like, what if you're in your crystal ball? What's the future of this?
Yeah, it's a good question. I think that we will see definitely the digital dental world help us a little bit. So that's going to help us, for example, in the immediate. So like if I look at, for example, cases that I've been doing this year, so 2023, already we're printing out every single model that, of the jaw defect that I'm trying to treat. So it gives me 3-dimensionally a view. I can hold it in my hand, and obviously I can, which I'm doing, is sterilize it, and I can already pre-trim the membrane, which allows me, a lot more precision, and allows me also to save time during the, intraoperative, period.
Okay.
So that's an immediate advancement, which is just going to improve. And obviously, when I train the colleagues who come, to train with me, that's kind of what we teach them today. Like, hey, you know what, you got to jump on that digital bandwagon, either in your office or through some support company, but you got to get these models. Secondly, of course, biologics. I mean, we've been working biologics for a long time, but I think like the aspect of soft tissue healing definitely can be enhanced for wound healing, like with some of the products that we have available, in these tissues which are kind of really coronally positioned. I mean, it doesn't hurt to improve that. We're not substituting anything, but we're supplementing. For example, in patients I do a lot of cases which are referred, who've had previous grafts or failed implants or partially failed procedures. I mean, it helps me to have some more biologics in there. And then maybe thirdly, let's see what happens there. And that's maybe something also for you guys to look out into, is like, this whole 3-dimensional custom, titanium mesh development. It's obviously very interesting because it follows the same guided bone regeneration principles. It's micro perforated, and it's still using membranes, but then resorbable membranes to hold the overall site. So I think it's, I guess, threefold. So one will be like, digital. It's going to help us to do things before the surgery, less surgical time. Definitely will help, like, the clinician who doesn't have like under his belt, like, hundreds or thousands of membranes that they've trimmed before. Secondly, I would say biologics. We're going to see more of that. And then thirdly, let's see, the next generation, if those space maintaining cages who were developing, in the computer and then printing in the computer can help us again to be stable. So that's my, kind of as good as I can see right now.
Yeah, I appreciate your answer. And before I ask my last question, we had one other sort of like very like tactical question. Do you do your CTG grafting at the time of implant placement and GBR, or do you do it after uncovering the bone healing?
Okay, Well, I appreciate the question because, you know, I was one of those lucky guys who was, of course, mainly interested in implants and tissue regeneration, but I was lucky enough to fall into periodontics, and I was trained as a classic periodontist at UCLA School of Dentistry. So I learned, and that was an amazing mucogingival, you know, school at UCLA with Dr. Takei and some of his other colleagues. And so basically, in the early days of implant placement and GBR, I kind of noticed right away that if we want to achieve some type of aesthetic outcome, you know, in addition to bone regeneration and implant placement, we need two other factors. One is we need to have a really thick soft tissue bed. And that was, of course, came from CTG grafting. And I think I published that around 97 or 98. So it's also like 25 years ago, maybe now. And then secondly, I learned very quickly that the vertical implant position needs to be in relationship to the periodontal tissues, or like, you know, in this case, the peri-implant tissue. So that became that global standard that you see today, that we're placing implants about 3 to 4 millimeters below the, let's say, desired gingival margin. Mm-hmm. So I definitely do CTG during implant placement, but I do it also before, I do it after. So soft tissue augmentation or management is like as important before as it is during, as it is after.
So you may do it during, and then if you need more tissue, you'll do it again after.
Yeah, what happens very often, Shane, is like, which a clinician will see quite often, is like, because we're coronally repositioning and advancing these flaps so much that often we eliminate the vestibulum and the mucogingival line.
Okay.
So then as we're uncovering them later on to place any kind of temporary on it, you know, we have diminished vestibulum and we have very little to no keratinized gingiva. So you basically need to reestablish the vestibulum and need to establish some keratinized gingiva.
Gotcha. Yeah, makes perfect sense. So last question, and I appreciate all your time this evening. So I know some people, and we've got a couple of messages related to this as well. So, you know, people are getting into this. They want to get more into implant dentistry. They want to get more into, of course, regeneration is the necessary skill set you need to develop if you're placing implants. What is your suggestion? You know, where do you start? What does the educational sort of journey look like? And then also, you know, I'd be interested, how does guide fit into that?
Right. Sure. Well, I have the perfect answer for you there, because obviously this is what I've been working on all my life, to like develop some kind of program that really is useful to the dentist, so to the practitioner. So if you really want to dive into, like, you know, heavily into tissue regeneration, like we've been researching for so long and publishing for so long, at Guide we have this 4-day regeneration program that's basically 3 times a year in Los Angeles, and I'm the predominant teacher in that one. So I'm there all 4 days. I do have some colleagues who help me with the workshops, etc., but I'm there. So if you guys want to like learn about regeneration and really how to use these biomaterials, especially, you know, the osteogenics ones, that would be the perfect course. Then I created with a large faculty like a whole implant program, because obviously, you know, tissue regeneration is just as good as the implant part or therapy that you do. Yeah. So I created like about 15-16 years ago now, the so-called 1-year master clinician program or diploma program. Yeah. And this is really for the clinician who wants to take a deep dive into becoming an implant clinician in control. I think that's the easiest way for me to say it. And to be an implant clinician that is, you know, working at the highest level they can do. And so that's like a program which is very, very, you know, high quality, evidence-based, and basically presents all the clinical protocols you need in implants. And then thirdly, I have, for everybody who is like just interested in watching videos, we have the Guide video library, which now is like pretty much on fire, because it's like every week there's a new video from an, let's say, selected, but usually like very high quality clinician from around the world who present, like, you know, soft tissue management, sinus extraction, ridge augmentation, implant therapy. So that's the guide video library, which comes in, basically on your app. So before you go into surgery, you could just watch that and say, okay, I need to see that GPR one more time. Okay, where does he put that incision, or how does he do that suture? There you go. It's right there. So those are the 3 options that we have created here at Guide. And I'm kind of proud of it because it's took a long time to do all this here. But we're very fortunate that we can do this and that many clinicians are enjoying that.
Yeah. Congratulations on building that platform. I know it's a platform that many have been educated through and rely on. And so to find out, you mentioned the 3 4-day courses. When's the next one coming up?
The next one, I believe, is coming up in March.
Okay.
But let's say in the first quarter of 2024.
And to find out more information, where do they go? Is it go to of course, Instagram probably has some information, but is it guide.com, GIDE?
No, it's a Guide Dental. So GIDE-dental.com. Yeah.
GIDE dental.com to get more information on that, as well as the Master Clinician Program, as well as access to the videos. And then we also have partnered with you guys on the Osteogenics site. We offer some of these videos specific to regeneration that kind of use our products. There's also, I think it's around maybe like 10 to 12 videos that they can see by going to the Osteogenics website. Well, hey, I really appreciate your time and working through the technological challenges to begin, and then sharing so much information with us this evening.
Okay, Shane, and I have a question for you. Where are you located nowadays? Are you still in Texas?
I'm in Lubbock, Texas. Yes.
Okay.
Yeah.
Good.
The proud home of Osteogenics Biomedical.
Excellent. And how many people we have on the Instagram feed right now?
Right now, and we're starting to lose people as we're kind of winding down. But it's 20 now. It was I think there've been a couple hundred on.
Couple hundred. Yeah. Okay. Well, definitely, what you could do, Shane, is I'm happy to support that. It's just we can give them an offer for the video library for especially here in the US, it's Thanksgiving, right? So I don't know if you have ways to reach out to them, but we can give them a significant offer so they can at least jump into the video, at least to see these procedures in tissue regeneration.
Well, that'd be great, because we're going to post the recording, and usually we get, we may just have a couple hundred tonight because, everyone has busy evenings with family and such. But, whenever we post it, the recording, usually we get a few thousand visits. So maybe we can, I'll have Eric get in touch with your team, and let's post that as an offer. I know that the viewers would love to see that.
Yeah, we could even do if you like it, and if our viewers like it, we could do even the tissue regeneration. Just give them a little offer to incentivize them to learn how to do this in the best possible way. Okay.
Yeah, we'll try to post a code or something. We'll figure it out here in the next 24 hours. But I think that's a great idea. Very generous. Yeah. Well, hey, thanks.
That's most people in Los Angeles are very generous. I don't know if you knew that.
No, I didn't.
Well, maybe because I'm a transplant. Maybe that's why.
Okay. No disrespect to Los Angeles, but I didn't know that it was more love came from LA than the rest of the world.
We have a lot of love here. A lot of love.
Hey, well, thanks, Sascha. Appreciate your time and your wisdom and your friendship, and thanks again. Have a great evening, and look forward to catching up again.
Very much so. Thank you so much, Shane, and thanks to everybody who was there. Bye.